Fortunately, ruxolitinib is a well-tolerated drug. In my experience, patients complain a little bit of the weight gain, which is expected. It's important to check their lipid levels. It's important to advise them that they need to pay attention to their cardiovascular risk factors, not just because they're on Rux, but because they have PV as well. So it's important to aggressively manage cardiovascular risk factors and know that they are on a drug that will actually increase cholesterol and weight. Occasionally, you run into a situation where non-melanoma skin cancers become an issue, and the response trials actually showed us that if patients had a history of this, then that is more of an issue. So that's something to be careful about. Fortunately, it's not a very common occurrence, but it's something that one has to be aware of, because clearly the immunosuppressive effects of JAK inhibition can increase that risk. Otherwise, you can get headaches, you can get some bruising, some dizziness, but really in my practice, these have hardly ever been significant issues or led any patient to discontinue. We now have 5 years of data from the response trial. This was presented at ASH 2018, and the efficacy and safety are holding up. The probability of maintaining the hematocrit control, spleen volume reduction, all of that, the hazard ratios are quite favorable. We have, now we have, like I said, 256 weeks, so that's a pretty good follow-up. No new safety signals have emerged since the 80-week analysis. So again, that's pretty reassuring that the drug not only works for a long time, but also that no new concerning side effects develop. So I think with 5 years of follow-up, it's pretty reassuring data at this point. Rux is currently approved for hydroxyurea resistant or intolerant patients, so that's a second-line indication. It's interesting to speculate on whether Rux could become a frontline drug. One has to consider, however, that hydroxyurea resistance or intolerance is not super common. So, right now, it's been suggested that about 20% of patients develop hydroxyurea resistance or intolerance. Clearly, Rux will work in the front line, I would think, because the mechanism makes sense, and if it has worked in the second line setting, it should work in the front line setting. From the viewpoint of the competitive landscape of drug development, there is an agent called Ropeg interferon alpha, which is being developed in the frontline setting and recently got a positive opinion from the EMA in Europe. I believe there will be trials in the United States as well. So this is a drug, it's an interferon formulation that actually was shown to be non-inferior to hydroxyurea at 1 year in the frontline setting, and then with 2 and 3 years of follow-up, it actually seemed to be better. So I would assume that something similar would need to be done versus hydroxyurea in the frontline setting for such a development path for ruxolitinib.